Fellas, don't panic or anything, but I think I forgot about a-fib and a-flutter. Oh no, what do you mean? Isn't he on the medic unit? This is a disaster! I thought you were better than this, you sack of... I think I'm gonna puke. I feel sick. And why are the numbers on my face? Fellas, don't panic. I'll teach you all about a-fib and a-flutter. Wink. Alright guys, so we're gonna be going over a-fib and atrial flutter. So, my name is Mario Martinez, and this is Amateur EMS. This is going to be the 6th video on our playlist going over EKG interpretations. Make sure to check the EKG playlist for some foundational videos. It's really going to help you move along through this video, okay? So for EKG, rules of interpretation. Number 1, we want to look at the P waves and make sure they're upright. Number 2, we want to make sure that the PR intervals is less than 0.2 seconds from the QRS complex, meaning that they're not bigger than one of the big red boxes that we're going to look at later. Number 3, we want to check out how many P waves there are. Are there more than one present? Number 4, we want to check out the QRS complex. Is it less than 0.12 seconds or is it greater than that? And number 5, do the P waves and the QRS complexes match up? Do the P waves match with the P waves? And do the QRS complexes match up with the QRS complexes? So especially rule number 1, rule number 3, and rule number 5 is going to be really important. I should have underlined this too, whenever we're taking a look at our rules of interpretation versus our different rhythms. So before we look at these rhythm strips, we want to know some background information. So atrial fibrillation is one of the 2 main types of atrial rhythms. They're the most common sustained arrhythmia in adults as far as the atriums go. And it's characterized by rapid, disorganized electrical activity in the atria. It leads to ineffective atrial contraction, causing irregular ventricular responses. And this rhythm is irregularly irregular. Now, Mario, what do you mean by it being irregularly irregular? Well, here is an image of atrial fibrillation. We're going to go over 2 of them for each one. So we can see here, just right off the back, that the QRS complexes aren't matching up with each other. That's really weird, right? And at the same time, a big thing about a-fib is that it doesn't have a discernible P wave. Now, as you are a student, you may be looking at this or whatever you are, and you may say, oh, the P wave's right here. But is it? Is it right here? Is it right here? Here? Who knows? What about over here? Is this the P wave? Some students early on are going to be like, oh yeah, the P wave's right here. Oh really? Or is it this? Or is it all of the above? And that's whenever we start to describe it being a indiscernible P wave. We can't really tell where the P wave actually is. And that's because the atriums, the right and the left one, are fibrillating or they're quivering a lot. So they're not getting complete beats. And you can see here that it's very obvious in the P waves because that's when we know that the atrium is contracting. And sometimes it overlaps some of the T waves. So we can't really even distinguish what the T wave is. We can't really distinguish what the P wave is. So it's irregularly irregular because this is an irregularity here. And then this is an irregular beat. So if you do a manual heart rate, which I would highly recommend for these a-fib patients, what you want to do is put your hand over their right wrist or their left wrist, and you want to count out the beats either for 30 seconds and multiply it by 2, or 15 seconds and then multiply it by 4, and that should give you their overall heart rate. That's really important to gather for these a-fib patients. And that's going to kind of gauge us where our patient's actually at heart rate wise. Now we have to be really careful. Whenever people have this quivering rhythm with their a-fib, we want to make sure that they're taking blood thinners. Is this a new onset or is it a chronic onset? If it's a chronic onset and they're taking blood thinners, okay, then it's probably being managed by a cardiologist. But if it's new, we want to be really careful with this because the atrium is churning blood constantly, but it's not pumping it to the ventricles. And if we keep blood stagnating for a certain amount of times, clots can form. And ALS individuals may be really excited. They may want to synchronize cardiovert them. But are we doing more harm than good? We're going to talk about it later. But we may be sending blood clots from the atrium, push it over to the ventricles, and then eventually it can lead over to the brain, causing an acute stroke. So we want to be really careful how we treat these. And you want to contact medical control before you do so. Here we have a second image of an a-fib, and we can see here we have this irregular beat here with the QRSs, and each R wave here, which is going to be up here, is going to kind of be our heart rate, right? So if we look at our boxes, we can see that some have almost 2 boxes, some have a little bit greater than 1 box, and you can't really discern where the P wave is. Some people may argue like, oh, I think this is the P wave. Don't be one of those people, okay? This is clearly an indiscernible P wave. We can't really tell which one is our actual P wave or if there's just multiple P waves. You want to do a manual heart rate. If this, for instance, was a 6-second strip, it'd be 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12 times 10. That's going to be a heart rate at about approximately 120 beats per minute. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12 times 10. That's going to be 120 beats per minute. For atrial flutter, we need to know that it's less common, but a significant arrhythmia. It's caused by a re-entrant circuit in the atria, causing a rapid, regular rhythm. It's often associated with structural heart disease and can degenerate into a-fib or atrial fibrillation. So you're going to see here atrial flutter. It almost looks like a sawtooth where you can cut a tree with that, and we're going to take a closer look right here. So here's an image of atrial flutter. You can see here we have our QRS complexes. Now these match up, but along the way we have our atriums that are firing off complete beats, but rapid beats. So if we compare our QRS complex, and if this was like a 6-second strip, it's 1, 2, 3, 4, 5, 6, 7 times 10. So that's going to be a heart rate of 70. But if we look at our atriums, they're quivering like crazy. And the ventricles might be slowly contracting, but the atriums are contracting extremely quick, because they keep on repeating in this loop where it's like the re-entrant circuit. And what's going on is the SA node is firing off constantly. It's getting stuck at a certain part that we're going to go over later, and it's just looping backwards, and it just keeps on looping in a circle. The AV node, though, is going to stop those beats from going any further to the ventricles, because it's like, wait a second, this is nonsense. And it has like this moment where it's going to reset. So the atriums can keep on firing constantly, but the ventricles are like, no, no, no. The AV node hasn't sent us any information yet. We're going to wait all the way over here, right? So they're going to wait about, if each box is 0.2 seconds, they're going to wait about 0.8 seconds. But these are firing off every 0.2 seconds. So it's a good thing we have the AV node to stop this from happening. But remember, this can degenerate over to a-fib, and we really don't want that to happen. Here's a second image of atrial flutter. And we can see here the QRS complexes are persistent. However, we have these P waves that are forming, and if we were to turn this around and try to cut it with a tree, I'm sure we get some traction with these sawtooth blades. And you may be thinking, oh, I bet it doesn't look exactly like this in real life. It really does. Like, it is a beautiful rhythm to look at, but it is dangerous for your patient. So we can see here the atriums are firing off much faster than the QRS complexes are. But at the same time, while the SA node may be firing off, causing the atriums to contract, the ventricles, due to the AV node slowing down the actual beat, are firing off at a decent rate. But over time, this can cause issues. We don't want the atriums to be firing off quickly because it might not properly perfuse the ventricles. So pertaining to atrial flutter's re-entrant circuits, it might have been kind of confusing earlier when I talked about it, but basically we have this cavo-tricuspid isthmus, or the CTI, that's generally going to be this area that slows down the atrium so it can cause a loop or a reentrant circuit over here. That's fairly problematic. It can cause this irregular pulse where it just keeps on firing off constantly for atrial flutter, where we have a P wave, P wave, P wave. It keeps on having this feedback loop, but the AV node right over here is going to say, whoa, whoa, I know the SA node is firing off constantly. I'm not ready yet, so I refuse to send this further to the bundle of His. So we have the atrium going on, firing again and again, and you have these ectopic beats where it's just going to keep on firing off of each other. But it's going to take a moment for the AV node to pass it over to the bundle of His. Therefore, we have a consistent QRS complex. We have a much more rapid atrium fire off with these P waves here. So something to beware, at least on the EMS side, whenever you synchronize cardiovert these patients, be very wary of what you're doing. Think about what you're actually doing to the body. You can cause these clots to form from the atrium, churning blood over time to be sent to the brain, which can cause an embolic event, where a patient can have an acute stroke. You want to treat these with medications instead, usually, unless your patient is presenting with hemodynamic instability. Regardless, even if they are hemodynamically unstable, contact medical control or contact the receiving hospital before you do anything else, because you don't want to end up doing something and the ER staff member doesn't like that, and you end up causing more harm than good, right? Because yes, this is a big issue, but we don't want to end up causing a stroke and then to have two different issues if we reset it, because then the SA node gets reset, it pushes out blood properly, the atrium to the ventricles, which then send out the clots that have been forming or churning over time to the brain, causing a stroke. So thank you guys so much for watching. Understanding atrial arrhythmias is crucial in EMS and ALS. Each type has unique EKG features and treatment that's needed. Be sure to review the playlist for more on EKG interpretations. Thank you guys again so much for watching, and I will see you on the next one. Bye.